So I'd like to reflect on the recommendation that Dr. Brian Mittman left us with several weeks ago to take the time to understand why an intervention worked or did not work before launching into the next intervention. And so we've recently reviewed the literature on learning health systems in healthcare settings. And one of the looming questions that remains still a little unanswered is, what are the enabling conditions to bring about change in a learning health system? And this list here is not complete, but these are 3 enabling conditions that were absolutely critical. They emerged clearly from the COMPASS study, and I see them reflected in the literature as well. So first, the engagement from a broad range of stakeholders. Second, organizational readiness to implement change, which we can measure with the ORIC scale out of the University of North Carolina. It's published in Implementation Science by Brian Weiner. It was predictive of implementation success in our study. And now looking back, we can also create a checklist of specific structures and attitudes and types of people that need to be in place for a site to be ready to implement COMPASS. And then thirdly, administrative support for implementation has to be tangible. So it's space, time, people, money. Next, please. So as you know, PCORI requires engagement of stakeholders. They leave it up to each study as to how that will look. Because this was a very high profile, large project that spanned the state of North Carolina, we felt it was important to be very inclusive and leverage all the expertise we had in the state. And so we, for 5 years, very actively engaged the perspectives of a wide range of stakeholders. So we had patients and families, community agencies, clinicians, of various disciplines, policymakers, speak into every phase of the project. So from study design and the selection of measures based, for example, on the outcomes that mattered most to patients and not to health systems, all the way through to the dissemination of results. Next, please. Looking back, we'd say that stakeholders brought tremendous value to the project as a research study, and then also in terms of the pragmatics of delivering healthcare. So my strongest recommendation would be to ask, listen, and incorporate feedback, because people will be very blunt with you. Patients may couch their critiques saying that they love their nurses, but X, Y, and Z has got to change. And if you incorporate their voices and listen to a broad variety of patients, for example, you will often hear the same themes emerge. The other consideration we would do differently now in retrospect is spend more time with 2 stakeholder groups. And the first is payers, which from the start were difficult to gain access to. And this is something we have heard PCORI note as well across many of their projects. And PCORI is actually not even in a position themselves to help assist PIs in gaining that access. And then the second is health system leaders. We did engage them quite heavily during the design of the study to understand barriers that they anticipated so that we can incorporate that feedback into the design of the intervention and the implementation. And we engaged them very heavily during recruitment of sites into this study because there had to be a certain amount of commitment for sites to actually be able to implement. And after that, we didn't have any influence on their decision making. And as Dr. Duncan mentioned, there were a lot of competing priorities. And so those sites that continue to prioritize COMPASS are the ones that were most successful in their implementation. Next, thank you. So we had a number of stakeholder groups involved, and we tended to think of them in 2 stages. First, in the top, these key stakeholders who could sort of make or break the intervention. So from patients through to a variety of different care providers. They were involved in the intervention at a sort of high level, saying we need to incorporate these components, and into a very detailed in the weeds level where they designed what the refrigerator magnet said on. So we had sort of a range of participation, but the goal there was to make sure we were designing the right intervention and that it would be used by providers because it was user friendly. And then we had a number of regional policymakers, leaders in the stroke systems of care here in North Carolina, who advised us at a very high level to support dissemination of results and the sustainability of the project after the life of the grant. And a key partner was the American Heart Association at a national level. Next, please. So as we selected our stakeholder groups, we had to justify their participation. And what we did is use the social ecological model to impose a framework on who was important to include. And so in theory, if we included individuals in each sphere of influence on the patient's health, then we would have the biggest impact on the patient's health. Okay. So we've actually published, because we took very detailed notes. We actually had a database that documented when we engaged patients and other stakeholders, how we engaged them, what information they provided, what we incorporated, why we couldn't incorporate it. And we've summarized that in a publication, the Journal of Clinical and Translational Science. But to give you sort of a little color, there were components of the intervention as proposed that were refined by our stakeholders, and then there were new components added. For example, the importance was stated by patients and caregivers that we had to assess how well their caregivers were doing and connect them to resources in the community to support them, because they were critical to the patient's recovery. All of our documents that clinicians and patients received throughout the trial were vetted by those stakeholder groups in terms of including the care plan, for example, in terms of content, language, tone, which when we first presented our first care plan, the tone was quickly dismissed by a large focus group because it wasn't positive enough and uplifting and encouraging enough. And so we took that feedback and altered the tone of the care plan and sort of tinkered with it until our focus groups were comfortable with the language we used. And they were also very concerned with the timing of when information was presented to patients during this time of crisis, and then timing to providers to make their workflow easiest. And let me just go back one more. We also engaged stakeholders in the training of our providers. So it was our patient stakeholders who spoke directly to the care teams to tell them what it meant to be patient-centered in their care. And it was the caregivers that told the providers how to talk to someone with aphasia. And it was the resource specialists at the Area Agency on Aging that spoke to describe all the local resources that are available, most of which neither patients nor providers were aware of, as well as the barriers that patients faced in accessing them, and how providers could connect to them. Next, please. So as Dr. Duncan had mentioned, COMPASS was not easily incorporated into the existing systems of care. There was variability. So for example, we had some sites that were able to deliver a billable intervention to 70% of their eligible patients, and some that were able to do that to 10%. And so everything in between was present as well. Even though we had all this engagement, even though the intervention was designed to be consistent with CMS billing policies for transitional care management. So then we asked, so what really were the drivers of uptake here? And that's where we decided to look at who were the patients most likely to get the intervention, who were the hospitals most likely to deliver the intervention as intended, and how well did they do in delivering the intervention as it was designed. Next, please. And so we looked at all 20 hospitals across the state that were randomized to the first phase of the intervention, and about 3,000 patients, and used the REAIM framework to assess who was reached, what was done, where was it adopted, how was it implemented, and how long were the hospitals able to sustain the intervention after the study team pulled back all support. Next, please. This is just one snapshot. It's sort of at a glance that shows very clearly that we did quite well in many domains and that the pain point was reaching eligible patients. Next, please. And so then the question is, who were the patients most likely to get the intervention as designed? And what we found is that it was those who were new to a stroke, those who had insurance, and those who were met in person at bedside before they went home and were reassured that there was a program in place to provide care that could not be provided in the hospital, but was just as critical to their recovery. The single biggest barrier to patients coming back to the Compass Clinic within 2 weeks of discharge was that they preferred very strongly to see providers they already knew, which was typically their primary care provider or their cardiologist. Okay. And then if you look, we looked at what are the hospital level drivers of implementation. And we found that it was the Compass clinics that were set within their neurology in non-urban sites, which was a little surprising. And you should know that many of our sites had never had any research experience when they participated in this pragmatic trial. And then we'll go into a little more detail on those that were organizational ready and had not just enough staff and backup staff, but the right people. And again, the single greatest barrier to implementation was the staff turnover rate, as Dr. Duncan mentioned, that there simply often was no backup in place. And that is what prevented many sites from delivering the intervention consistently and reaching as many patients as were eligible. So the organizational readiness to implement change scale is validated. We've offered the sort of predictive validation with this study, and it really taps into the extent to which the care team, those intervention agents, those responsible for implementing, are committed to the care model. They understand the value. They can communicate that internally. They feel confident that they can manage internal politics that will come up as they try to implement change in their environment, and that they personally have the abilities to bring about change in the current environment. And when we saw sites that were scoring high on this ORIC scale, we later also saw that they implemented extremely well. And some of the markers of their success was that they initiated implementation very quickly after training. They were able to anticipate problems, they could address them, and they were very proactive in reworking their own workflow to make the processes work best for their providers. And then they leveraged relationships inside the hospital, up to the board, and outside the walls of the hospital with the community-based agencies that were there to support recovery, but often not utilized. Next. Staffing was again critical. Here we see that the team in Lenore, a very rural community that was unable to find a second post-acute care coordinator to man their clinic. And so they thought creatively and went out and found a community paramedic who then became the nurse's backup. They initially had some personality problems, and they worked through those because they both valued the program. They were both very committed to implementing the model. They each had authority within their unique systems, and they used it. And they had consistent administrative support. And they very much saw Compass as their standard of care, as opposed to a research study that was added on to their existing responsibilities. And so, for example, they added the Compass metrics that we provided in a regular fashion for them to monitor their own implementation to their performance measures, so that they could follow it along with every other performance measure they were tracking to improve their success.